tell you, this patient is a 50-year-old who has taken several courses of antibiotic steroid somewhere, and we did a lot of assessment of this patient who had polyps also. And this is the picture after the steroid course, what you are getting.
Oh.
Yeah.
So first of all, in the chronic rhinosinusitis, the role of CT scan, the timing of CT scan, and the kind of CT scan required. So the role of CT scan is not for diagnosis. 99% of the time, sinusitis can be diagnosed on the clinical grounds. With clinical history, the most important is the history and then endoscopy. The CT scan is required to give you anatomical details for surgery, to rule out any other thing than sinusitis. That is the second reason to order CT scan. If you suspect something else, like you have some funny symptoms which warrants you to get CT scan, and the patient sometimes says endoscopy is negative, history of cold, recurrent cold, this and that, and severe headache, then you have to rule out something else, at least to rule out that this is not sinusitis. But most of the time when it comes to sinusitis, the role of CT scan is to give anatomical details for the surgery. And for that, the kind of CT scan required, what you see on the screen here, 0.5 mm on DVD. 0.5 mm so that you can reconstruct in all planes with full details you have on DVD. So like this particular scan.
Yeah.
This is 0.7 mm. See this. How many slices are there? 421. Because the area scanned is almost 25 centimeter. 0.7 mm, 25 centimeters scanned in the axial plane. Only axial plane. We shoot only in axial plane. And it gives 421 slices. Now let me reconstruct in all planes. How will it be? 1263 slices now. Now I will change my soft tissue window. Different window settings. See this?
Yeah.
Double the number of slices. More than 2500. How a patient can carry.
Yes.
दोनों दो हैं ये ले मैं पता हाँ दूसरा ले अंडर कर देना. So it is practically impossible to carry patient for all those printouts for 2500 slices. So it is not required as well to get, simply have the data in the DVD, only axial, and then your software will reconstruct to everything.
Yes.
And more than
This
that,
is
you
the
will get
DICOM software.
dynamic detail.
Dr.
You will
Satish,
get a dynamic detail in all planes. See that?
This is DICOM software.
This is DICOM.
Yeah.
So
Please go
now
ahead.
you get the dynamic information in all planes, and this is the best tool to learn the anatomy also.
Yeah.
Suppose I want to see which cell is this. See this cell in axial. You can see in the coronal, you can see in the axial and the sagittal, two anterior cell, two anterior. It cannot be anything else than the intersinus septal cell. See that? So dynamically you can see each and every structure right from the origin to insertion, which gives you 3D orientation of the structure you are going to deal with. You can get a print out and see this patient has a sinusitis, but that doesn't give a full dynamic anatomical information, because this surgery is the surgery having very low threshold of complication. You are millimeter away from the skull base and orbit. You have to have a complete 3D information of the surrounding. In some millimetric information, what you get dynamic is something important to prevent complications. That's why we need dynamic. Every structure you can find dynamic, information. Each and every structure you can get. This is uncinate process. See where it is going. It is merging with the, lamina, this agar cell, and going up to the lamina. Each and every structure you can follow. Sometimes on a snapshot, you may be confused whether it is onodi or not. See dynamic, whether it is onodi or not, how the cell is placed in relation to the sphenoid sinus, how it is going beyond the sphenoid sinus. Everything is possible. It simplifies your orientation.
Yes.
In sinus surgery, we have two goals. One is, like in this patient, we are going to do a full sinus surgery. We have two goals: to complete the procedure in one go with complete removal of the septations to ensure that drug reaches, the steroid reaches post-operatively everywhere, at the same time preventing complications. That is very, very important, because the margin of safety is very less in sinus surgery because of its close proximity to the orbit and right division. So this is how you need to look at the CT scan. Now, coronal is the most important. It gives you information in the same plane in which you operate. And you need to see the CT from beginning, see all anatomy of the nasal bone, the beak, below the floor of the frontal sinus, beak. This is the intersinus septal cell. Now the beak is going, the ethmoid starting. The frontal sinus is gone now. The ethmoidal roof has started. And this is what? The supraorbital cells, more developed on this side as compared to the other. And then it is the ethmoidal, the frontal outflow, the ethmoidal outflow. This is crista galli. And at this point, see this canal emerging from the orbit going to here to the skull base. This is orbitocranial canal harboring the anterethmoidal artery.
Anterethmoidal, yes.
See, if I come anteriorly, this is frontal sinus. Now see, I am going posteriorly. How posterior is the anterethmoidal artery? See now.
Yeah.
How posterior it is. So once you are operating in the frontal sinus, you don't have to terrified with the anterethmoidal artery. Let me tell you, if I run in all planes, where exactly the anterethmoidal artery in the anteroposterior plane. See, this, my cursor in the coronal plane is at the anterethmoidal artery. Now see in the sagittal. If you are operating in the frontal, your anterethmoidal artery is far behind.
Yes.
See, with this cross edge is the level of the anterethmoidal artery I have placed here. And see, this is the beginning of the ethmoid here. This is the end of the anterethmoid. And immediately behind the anterethmoidal artery is the beginning of the postethmoid. These three, 1, 2, 3 are larger postethmoidal cells. A millimeter behind the anterethmoidal artery. See, this is anterethmoidal artery here. A millimeter or so behind the postethmoid starts. So you can say the anterethmoidal artery runs through the posterior most part of the anterethmoidal roof. And that is the landmark for the beginning of the postethmoidal roof. That is how you can take this artery as a very good landmark on CT scan. So these are fine points. That reading a CT scan requires time. I am just going through quickly to run through some important points, and you can see the opacification everywhere.
Yes.
Some deviation of the nasal septum, extreme deviation. The sphenoid sinus, this is the pterygoid process, what we drilled in the mucor case. In mucor case, I showed you two nerves.
Yes.
Medially was the median and laterally was the V2.
V2.
And this entire process we drilled off right from here till here.
Yeah.
And the mucor was invading.
Yes.
And just about this is the floor of the middle cranial fossa. This V2 comes from the floor. See the opening. It comes from the floor of the middle cranial fossa as a branch of trigeminal and just about the temporal lobe. And when we drill this temporal, this pterygoid, I showed you the dura. That is the level of the dura there.
Yes.
This is how the tumors from here easily spread to the temporal lobe. You see the angiofibromas, many malignancies, and even the mucor
Yeah.
spread to the temporal lobe right from here. So this pterygoid is a very important anatomy, not in sinus surgery, but in other areas, other surgeries, and then behind is the sphenoid sinus with minimal opacification.
Dr. Satish, one message to juniors,
Yes.
those who are not very conversant as to understand radiology, it takes good time. Somebody asked about the DICOM software that can be downloaded. Free
Yes.
version is available on Google. And they must sit with the radiologist on the console and try to understand with him for the beginning. Is
Yes.
that
Yes.
correct approach? Yeah.
Yes. See, once you start acquiring your data in DVD,
Yeah.
with this software only you can understand the entire radiology in all planes.
Right. Yeah.
Because suppose I am running in the coronal plane
Yes.
and want to see what cell is what,
Yes.
you can easily see.
Easily.
See,
Yeah.
see if I run this, see now this is supraorbital cell. This is
Yeah.
supraorbital cell going
Yeah.
beyond.
Yeah.
This is supraorbital cell going beyond. Now see, this is about the orbit. See relationship to the orbit in all
Yes.
planes.
Yes. Yes.
Now if I am coming to the frontal sinus, you see all the frontal sinus in
Right.
all planes.
Yes.
Any possible cell, see this is cella,
Yes.
where my cursor is.
Yeah.
This sphenoid sinus,
Yeah.
could this be ONOD?
Yes.
See this? Yes, this the sphenoid sinus is dividing horizontally here.
Yes.
This could be possible ONOD on the right side.
ONOD. Yeah. Yeah.
Yes.
So the radiology can be best understood on the software.
Yes.
On this, if you acquire the data, the soft
And
data,
this gives a three-dimensional view, so hardly any structure that can be missed if you watch it
any structure
properly.
you can see,
Yes.
any 3D relationship,
Yes.
you can reconstruct in more planes, oblique sagittal,
Yes.
oblique longitudinal, oblique coronal, anything you can do. You can measure the
Yes.
distances, sir.
Yes.
Suppose you want to measure any distance. Suppose uh, you want to measure the distance from the anterior wall of the sphenoid to posterior wall. See this? Just a minute. Yeah, let me, any distance. Suppose sphenoid sinus.
Yes. Yes.
I can measure the distance.
Yeah. There is a scale. Yeah.
Angles, distances, anything you can do.
Yes.
This is your medial rectus muscle, and this is your lamina papyracea anteriorly. There is 4.5 or so, 4.8 millimeter fat
Yes.
between the lamina and the muscle anteriorly
Muscle.
in the anterior
Yes.
sigmoid.
Medial.
Posterior sigmoid, there is no fat in between. If you injure
Yes.
the lamina, your muscle is right there.
Yes.
Any distance you can measure in any plane, any angle. This is carotid artery. This is the prominence of the carotid on both
Yeah.
sides.
Yeah. Mm-hmm.
So radiology, you can ask me anything. It is, I'm not going in detail myself. These were the fine points I touched upon.
Yeah.
Anything, any questions so far so that we can go ahead with the case? I'm going to
No,
demonstrate
please
case
go
on
ahead
both
with the
sides.
case, sir. Yeah, please. Go ahead, sir.
Okay, sir.
For the viewers, apart from DICOM, there is another software, Horos, which is also available almost free of cost. Probably it's free of cost.
On Mac, on the Mac platform, it is Osirix,
Osirix, yeah.
same like Radiant.
Yeah. So what was the presentation of this patient, Satish?
This patient is a classical, nasal obstruction, nasal discharge,
Mm-hmm.
sometimes headache.
Okay.
And on endoscope, it was very obvious of sinusitis. Had
Yeah.
good response in between with the antibiotic steroids.
Okay.
That's why he has been, passing
Pulling on so long. Yeah.
treatment several times.
Yeah.
Yeah. So in sinus surgery, the first thing when it comes to surgery is the preparation.
Yes.
We need to prepare our patient thoroughly to get a good surgical field. The preparation has a role to improve the surgical field, and that should start even days before the surgery to reduce the vascularity. This is unprepared nose. Can you see? Hello?
Yes. Yes.
See, no decongestion has been done so far. Unprepared. And what you see there are the polyps. Can you see?
Yes.
Yes. Yes.
How is the picture now? Yes. Over the gauze.
Excellent. Now you are out of it.
Okay. So now, as I was talking about the preparation, pre-operative preparation is important, and equally important is the intraoperative. In pre-operative, we reduce the inflammation by giving steroids. If secondary infection is there, then antibiotics as well. And intraoperatively, decongestion to reduce the vascularity. And the best way of decongestion, what we believe, we have stopped infiltrating for more than 10 years now. See this?
Yeah.
This is the marrow cell sponge, a piece of marrow cell. We divide the marrow cell in 8 to 10 pieces, 2 marrow cell, soak in
Yeah.
saline adrenaline. This is 1:1 combination. This is not a cardiac patient or anything. And we can use it topically, not for infiltration. No infiltration at all. Just topical application you can see to improve the status of the mucosa to decongest the capillaries. In this surgery, the main source of bleeding is capillary, not the arterial like tumors like angiofibromas. It is always the capillary bleeding which is need to be controlled, which is responsible for the, good surgical field, responsible for the bleeding. Now see the picture after the first application of the.
Yes. Yes. Yes.
It has opened up the space.
But-
There was hardly any space earlier.
But
Yeah.
And
And
see,
the-
this is simply application. You don't have to press hard this.
yes.
Our job is to apply adrenaline, not to apply pressure.
For how long you keep the adrenaline?
This entire decongestion requires 5 to 10 minutes, sir.
Yes.
To all
Okay.
mucosal surfaces. Why I'm saying not to press hard is, if you press hard this marrow cell on the mucosa, it is going to be counterproductive.
Yes.
By means of blocking the venous drainage, it will rather result in more bleeding. More troublesome, more frustrating bleeding. So never pack tightly with anything.
What is the ratio of the saline and the adrenaline?
This case, 1:1 I am using.
1:1. Okay.
In elderly cardiac patients, I can dilute to 1:4. In young patient, children, I don't mind using pure. 1:1000.
Okay.
Okay. And steroid pre-op, how long you give? 3 to 5 days?
Yeah, 7 to 10 days, depending upon the other condition. Sometimes
Right.
we have a long distance patient who come for surgery. We tell them on phone to start some treatment. Sometimes we don't have too much time for the patient to stay and all that. We may have to do in 3 to 5 days. But yes, in routine planned patient, 7 to 10 days at least.
7 to 10 days. Dr. Man Prakash Sharma is watching And he has commented great surgical demonstration, dear Satish.
I am his, he is my favorite teacher. I am
Yeah,
grateful to sir.
yeah, that's why I brought it.
Thank you, sir, for always being with us. He's a great person,
Yeah,
great teacher, and a lot to learn from him always. He encourages always, supports always for everything.
yeah,
This is the middle meatus now. My pack is in.
yes,
Decongest. See, the polyps have been decongested.
yeah,
The initial picture, what you had seen and now, is altogether different.
right.
I showed you the unprepared nose with full of polyps,
Yes.
and now see.
Dr. Satish, one thing, most of the people want to do it under local anesthesia, and in that case, the preparation will be altogether different,
Let me tell you about that. See what I'm doing here. It's out fracturing the inferior turbinate
Yes.
to get more space,
Yeah.
Now coming to your point of local anesthesia.
Yeah.
Number one, why it was introduced earlier. Why we always discuss. Local anesthesia gives you a great feedback.
Yeah.
If you cross your limits of sinus cavity and approach to the adjacent area like skull base or orbit,
Mm-hmm.
whatever local anesthesia, good anesthesia you have given, patient will invariably experience the pain.
Yeah.
And that is amazing feedback to the surgeon that you are crossing the limits.
Right.
So that is the value of the local anesthesia, how it was introduced.
Yes.
But now, with the advancement in the anesthesia technology, with the advancement in the anesthesia, with good, prevention of vasodilatation. Local anesthesia, another advantage was you can reduce the vasodilatation. That is one of the reasons for more bleeding. And it was supposed that the overall bleeding is less in local anesthesia as compared to general. But now with the advancement in the anesthesia technology, we can have a better field under general anesthesia, number one.
Yeah.
Number two, you can more freely use the powered instruments.
Yes.
In under local anesthesia in a wake-up patient, if you use a debrider, is a you can think of if somebody is running some drill in your head.
Yeah.
How much discomfort one can expect. So the cooperation of the patient is a big problem sometimes. And third is the airway security.
Yes.
Now we are so secure about the airway with the intubation, cuff, the throat pack, and then we leave another pack over here. There's no question of any aspiration.
Yes. I think airway security and the hypotensive anesthesia or the technique of anesthesia which gives less hemorrhage is probably the key.
Pardon?
The hypotensive anesthesia nowadays giving less and less of the bleeding, controlled bleeding, and secure of the airway is probably much more important.
Yes. That's why we always do under general anesthesia.
Yes.
Now this is about the preparation part. I told you 5 to 10 minutes.
Yeah, it is.
Topical application.
Yeah.
I keep the head 15 degree up for the better venous drainage from the head. This is the only preparation we do intraoperatively.
Yeah.
No injection, no infiltration. Infiltration has its own adverse effects. They have been proven, published. Infiltration going into one of the internal carotid artery circulation, anterothomoid circulation going to the ophthalmic artery leading to blindness.
Yes.
Yes.
Infiltration going in the systemic circulation leading to arrhythmia, cardiac arrest reported. So why to take such a chance in such a benign disease unnecessarily? Now see, these are polyps which have been compressed. See this? All these are
Sir,
polyps
one more question, sir.
Yes.
completely
Sir,
decongested.
Sir, what about the heart rate? Would you like to comment something upon that?
Yes. So, our patient, let me tell you our monitor. I tell you, we never believe in hypotensive anesthesia. Always normotensive. We don't want to put our patient under risk. See this. If you see our monitor, our blood pressure is 133/89. Can you see?
Yes.
Yes, sir.
Mean blood pressure 104. No question of hypotensive, but look at the pulse.
Yes, sir.
around 50, 60.
Yeah.
Reduced cardiac output is the major determinant of the overall bleeding, and that is achieved best by bradycardia.
Yes, sir.
And it is safe for the cardiac patient also. You reduce the cardiac output, you reduce the cardiac load.
Yes.
So the best thing is to reduce the heart rate rather than reduce the BP. In a cardiovascular labile patient, coronary labile patient, a reduction of the BP can result into ischemia.
Yes. And
Now the first thing what I am doing is
by giving repeated injections, yeah,
debridement of the polyps. Yes, sir.
yes. I said by giving local
Pardon, sir?
injections, you create the mucosa to be unhealthy. Yeah.
Yes.
You have some bleeding points with the needle points, So,
See all these polyps I am removing. And you will
Yeah.
be able to see the anatomy better now.
yes.
Now I can see the landmarks better in the lateral nasal wall.
Yeah.
This is your uncinate process. This is your bullite modulis. This is your middle turbinate. Can you
Yes.
see better now?
Yes. Yes.
Yes, sir.
After debridement of all the polyps now
Yes.
here, again I will use my marrow cell. We call it as a magic marrow cell at this point of time. Soaked in the same solution. I told you, we cut in 8 to 10 pieces, soak in the same solution, again and again, rinse into the saline, soak in the same solution. Throughout the surgery, we can use it at the end of the surgery. Soaking in the steroid, we can pack in the ethmoidal cavity as well. Gosh. So just apply the marrow cell for few seconds to take care of the oozing. See this?
Yeah.
See, this is a soft pack, not a pressure pack.
Yes.
Just to apply the adrenaline, I am leaving this gauze in the nasopharynx to prevent trickle behind.
Yeah.
Why not marrow cell? Why this pack? Because you can suck over the pack better.
Yes.
Now see the field. Wash. Every time you can improve the
It's
field.
bloodless. It's bloodless as well as you got more space to work also because of the decongestion.
Yeah. See this? Now, coming to the steps of the sinus surgery, I'm going to show only one side.
Yes.
This is the same repetition I've shown so many times. So the first step of sinus surgery starts with the uncinectomy.
Unseen it.
So important a step to carry out a total uncinectomy. Improper, incomplete uncinectomy can be a cause of mechanical cause of failure, which is certainly avoidable.
Yes.
Sir,
You said you have demonstrated so many times, but I think these steps are probably the foundation stone, In spite of telling so many times, still proper uncinectomy and everything is very, very important. Yes, Dr. Kranti, you wanted to add on something?
no, I just wanted to ask Jain sir's view regarding his enterostomy size. There was this
Yes.
webinar where I just, the concept of mega enterostomy and enterostomy depending
Yes.
type of lesion which you're operating
yes.
upon. So
Yeah,
what
yeah.
do you do? Sort of, have you had a plan for enterostomy size disease wise, or it is somewhat
Yes.
uniform for?
Yes, that's a very important question from Dr. Kranti. See, first of all, why this question arises? What is relevant to the size of the enterostomy? The reason is earlier it used to be believed like a bigger enterostomy can lead to more air currents directly coming to the maxillary sinus, leading to headache. It leads to diffusion of the nitrous oxide, which doesn't concentrate, which is considered to be bactericidal and can be hazardous. It has all been disproven, number one. Number two,
Literature has
the size of
disproved
the
it.
enterostomy now is related to the demand of the topical steroid post-operatively.
Okay.
For example, the patient with a massive eosinophilic profile, I
Yes.
would like to
Yes.
create a mega enterostomy to deliver
Mega.
more and more topical steroid.
Yes.
Yeah.
Patient with a more massive fungal disease, I would like to create a more massive mega enterostomy for the lifetime surveillance. You know, lifetime irrigation, surveillance, more steroid going in, all are the purpose for mega enterostomy. And second is for non-sinus surgery as an approach to go behind. In a regular
आ जाओ कोई
situation,
बात नहीं बेटा ऐसे भी आ सकते
not having massive mucosal disease, not having massive eosinophilic disease, there is no point in creating a mega enterostomy. That is the perfect way of, defining the need of mega enterostomy, I believe. Now, this is your uncinate process. Can you see?
very well sir
Everted.
Yeah.
See this everted?
Very
Why it
clear.
was everted?
Everted, yes.
Yeah.
Because of the polyps.
polyp disease. Yeah.
See, this is uncinate. This is uncinate. Why it is uncinate? Sometimes
It
there
is
are
mobile.
you can't identify uncinate so easily. See this. See the mobility.
Yes.
Yes.
Only structure in the entire nasal wall, from anterior to posterior, right from here. Nasolacrimal, that this, bulla, everything there, the only mobile structure is uncinate.
Uncinate.
So in difficult situation, you can identify the uncinate very easily by its mobility. And you must be able to identify it properly as well, because in the beginning, if you are disoriented, you are likely to give complication by means of entering into the orbit or anything else, because this uncinate has a closest anatomy with the relationship with the orbit. Immediately lateral to the uncinate is the orbit. I will show you. So that is important. So now where to go, how to remove? See, this is uncinate, this is bulla, in between this is a two-dimensional hiatus semilunaris inferioris, okay?
Yeah.
And this hiatus leads into a three-dimensional area where my probe is going.
Yes.
That is infundibulum.
Yes.
And in the infundibulum laterally is the ostium of the maxillary sinus. So my goal is to uncover this area completely. So what I will do, I can remove this uncinate using a sickle knife also here. I can take a sickle knife right from here to here, but you never know. This orbit is very close to the, laterally to the uncinate. You can enter into the orbit very easily in the
Yes.
beginning. So the best way is go behind. We know the space
Right,
there,
right,
that is infundibulum. Go behind, engage your reverse biting and bite through it. Come anteriorly and bite through it. This step is known as infundibulotomy.
Yes.
The only concern while coming this anteriorly is the nasolacrimal system.
And
Yeah.
release it.
Yes.
You have to be careful. If you find any hard thing coming across, stop there rather biting through the nasolacrimal system. See, I'm just removing. What I have done is infundibulotomy.
Yes.
This three-dimensional space is infundibulum,
Yes.
where the polyps are coming. Now, this is uncinate upper part, this is uncinate lower part. See this? Now I fracture the lower part of the uncinate. See this? To open up the maxillary sinus. This is middle meatal enterostomy.
Yes.
See all these polyps? See the maxillary sinus?
Yeah. Beautiful.
This is the simplest way. I haven't removed the upper part of the uncinate yet.
Yes.
This is my red 40 microdebrider and a wide angle 0 degree. Though the interior of the maxillary sinus we will see later,
With a 70
yes,
degree.
with the 70 degree.
Yeah.
And see the massive, polypoidal mucosa. This patient has a eosinophilic disease. Profile is purely eosinophilic. I will create a little
Bigger one.
bigger enterostomy so that I can deliver more steroids
Yes.
more effectively in the post-operative period.
Dr. Satish,
Yes, sir.
for the sinonasal polyposis,
Yes,
one
sir.
concept is now growing very well. regarding this ethmoidal part and the maxillary part, that
Yes,
people are removing the middle turbinate and superior turbinate entirely to prevent the further recurrence of the polyp. How do you see this, and how
Yes.
do you
Yeah. So this
propagate
removal
it?
of the middle turbinate
Yes.
is a great idea in certain situations. That removal, the definition of removal, we need to understand. Definition is not chopping the middle turbinate completely of the insertion,
Yes.
not completely chopping to the level of the skull base. Removal of the lower half of the middle turbinate,
Lower half. Okay.
two-third,
Okay.
to ensure the steroid going more effectively in a massive mucosal disease. And ensure that the turbinate doesn't fall back and close the ethmoidal access. In those
Okay.
massive mucosal disease situation, it is always better to resect the part of the turbinate. That
Okay.
doesn't mean that you chop it off completely.
What about the superior turbinate?
Superior turbinate, again the lower one-third, not entirely, because lower one-third of the turbinate, if you improve the access to the sphenoid sinus. Otherwise, the superior turbinate doesn't limit any access to any other sinus.
Right.
So only lower one-third, which we always remove.
Right. Right.
Always remove.
And one more question, sir, here.
Yes.
When you are approaching maxillary sinus, please enlighten us how to approach anterolateral and what could be the possibility to reach there.
Yes,
The
that's a
different-
great question. Again, I tell
with
you,
different instrument.
anterolaterally, to reach anterolaterally, first of all, you can use your 70-degree and your angle instrument, but sometimes it is not all that easy, and still it doesn't give that much of access. In that situation, what we do, the simplest way, if you want, I can show you.
Yes, sir.
We use the trocar and cannula to make an opening in the sublabial region, 4 mm opening, and
Yeah.
pass our debrider through that and 70 degrees from inside the nose. You can
Sir,
access
what about
each and every nook and corner of the maxillary sinus.
Yes. Yes.
so
And
what
what about
the
the-
pre-lacrimal approach, sir? Nowadays, everybody
Pre-lacrimal
is
is a
talking about
different approach. This is
pre-lacrimal.
not pre-lacrimal. Find out. This is
Obviously,
not
this is
pre-lacrimal.
sublabial, but do you go for pre-lacrimal approaches?
Yeah,
for,
let me pre-lacrimal again is a good approach for certain indications. Pre-lacrimal is simple, not to get confused with any other dankers or all. See, this is the what you call that piriform
Piriform
aperture.
aperture. Yes.
Yeah.
So, oh gosh, please, oh, then, let me put a Merocell here for a while. Yes. So in pre-lacrimal, this is your piriform aperture. And
Yeah.
your nasolacrimal duct is right here. See this? Coming
Yes.
more anteriorly here,
Yeah.
1 centimeter from the attachment of the anterior end of the inferior turbinate. So your nasolacrimal duct is coming here. To access the maxillary sinus head on,
Yeah.
what you can do, I can make a simple incision. See this? Very good approach. I
Yeah.
can make a simple incision at the piriform aperture like this,
Yes.
right deep to the bone, and
Yeah.
elevate this flap completely. Okay?
Okay. Okay, sir.
And then with the drill, I can make an opening in the anterior part up to the level of the nasolacrimal duct.
Duct. Okay.
That opening pre-nasolacrimal duct.
Oh.
You can open, you can go head on in the maxillary sinus, do your work, and come back, reposit your flap back here and put a suture. Without damaging the lacrimal duct, working anterior to it to enter into the maxillary sinus and work there. Elevate the flap and reposit it back is a pre-lacrimal approach.
Okay.
Okay?
And what about the inferior enterostomy approach combined?
Inferior enterostomy is now no longer practiced. Advent of pre-lacrimal, sublabial, enterostomy and dankers and all these approaches. Inferior is, it's a blind procedure. You can traumatize, and it is never a long-lasting approach. Okay? So this is the first part, that is middle meatal enterostomy. Okay?
Yeah.
Now the second part. This is my uncinate.
Yes.
Yes. I told you my concern is this uncinate is immediately medial to the orbit.
Orbit.
See this upper part of the uncinate, what I'm doing, going behind with the angle curate, come anteriorly. Every movement should be anterior away from the structures behind to prevent
Okay.
damage. Once you dislodge, you can debride it. You can use a through biting also. See this, completely debride the upper part of the uncinate and you will be right at the lateral limit of your dissection, that is orbit.
Orbit.
See the lamina papracia.
Yeah.
This is lamina papracia.
Yeah.
So while removing the uncinate, you have to be careful not to damage the.
Lamina.
Yes. That's why we don't recommend the sickle knife. Look at the CT scan. If the space is not much, not to use the sickle knife, rather use a reverse biting.
Yes.
Sir, I had one more question regarding Denkers. Yeah, in these angiofibroma, I also do modified Denkers for all these approaches. But I have had 2 patients with nasal valve collapse. Because
Nasal valve
you
collapse.
removed the piriform upper. Yeah, so it was actually alar collapse. And that's a
Yes,
very
so
big
that is
problem,
important.
sorting it out.
I always mention doing Denkers. See this. This is your anterior limit. You have to make sure that you don't come anterior to the piriform aperture at all. See, this is piriform aperture.
Yeah.
Yes.
To come anteriorly, this is your lower ala.
Yeah,
If
okay.
it is lower ala, then you need support.
Yeah.
So be careful.
So piriform aperture is the landmark that you should never cross.
Yes.
Okay.
Now see the important landmark here. I've already shown you the entire lateral limit of our surgery.
Yeah.
That is lamina papracia. That is the beauty of removal of this upper part of the uncinate. Okay. So my corridor lateral limit is lamina, medial limit is turbinate. Okay.
Yes.
Now this upper part of the turbinate, see this. This upper part of the is the uncinate. It fuses with the agar negi,
Agar
middle
negi.
wall of the agar negi, and then insert along with that on the lamina papracia. See that?
Yeah.
That is how I am removing. This is still with a 0 degree.
Yeah.
See the 0 degree, completely with a 0 degree so far, red 40. And see the entire medial wall of the orbit is skeletonized. Can you see? With complete mucosa intact. Now, at this point of time, see what you see in front is the bulla.
Yes.
Yeah.
I haven't done anything to the bulla. At this step, there is reason to, I will tell you, we changed to 70 degree to do the frontal sinus work. For the reason I'll tell you, because we have more landmarks at this point of time to carry out a safe and an easy frontal sinus work. Let me tell you. This is the point. And the thing which is important behind that is the 70 degree. Without 70 degree, one cannot carry out a good, confident, a complete, comprehensive frontal sinus work. Believe me. Now with the 70 degree. See the view with the 70 degree up?
Yes.
That is your axilla.
Yeah.
Now with the 70 degree view, see this bulla?
Yes.
See this turbinate? What I have removed is the part of the agar negi. See this? For my frontal sinus like, you know, it's like a box. See, this is the floor of the frontal sinus. This is all is the floor. Here is all is the frontal sinus right from anterior to posterior. And this floor is formed by this beak. This is beak.
Yes. Yes.
Okay? Give me a merocell, small merocell to show you clearly. Let me show it clearly. Anybody has any doubt in the frontal sinus, let me tell you the simplest way to carry out the frontal sinus work in the most difficult situation. Don't get confused. The frontal sinus is not difficult. What all you need to have is a 70 degree and certain landmarks in orientation. Simplest landmark and the simplest here is the beak. I showed you on CT scan the floor of the frontal sinus formed by the beak. See the beak.
Yeah.
Yes.
Secondly, this middle turbinate goes up to insert on the lateral lamella of the cribriform. So
Yes.
stay lateral to the middle turbinate. See this middle turbinate?
Yes.
All
Yeah.
the way stay lateral to it. Don't go medial to it, otherwise you can damage the cribriform. See
Yeah.
that? And this is the upper end of the bulla. This agarneji I have removed, and this is the beak, total beak.
Yeah.
All along the beak, between the medial and the lateral limit, there cannot be anything else than frontal sinus. 1000% it is always frontal sinus. If you have a clear understanding of three things. Number one, see this. I told you my lateral limit is what? Orbit. Medial
Orbit. Yeah.
limit is what? Turbinate.
Middle turbinate.
Turbinate.
This is all beak.
Yes.
And where the beak ends, is going to be what? The
Frontal sinus.
Frontal sinus. opening.
Cannot be anything else. All you need to see under vision is through the 70 degree. And see now, let me show you. See, I told you once you work far anteriorly here, you don't have to look for the anterothomoidal artery at all. See my beak, where the beak is ending. See where the beak is ending. What is there?
Yes.
Frontal.
Again. This is the beak. Can you see?
Yeah.
Beak, and the beak ending is frontal sinus. What you need to see is stay between the lateral limit, medial limit, go along the beak where it ends in the frontal. And you are working in the anterior trajectory. Your anterothomoidal artery is miles away.
Yes.
Yeah.
It is in the posterior most part of the anterothomoidal roof. Once you are working in this region, you don't need to terrify with the anterothomoidal artery. First, the beginning of the anterothomoidal roof is more than a centimeter from the beak. More than a centimeter behind is the beginning of the anterothomoid.
Yeah.
And the end of the anterothomoid is going to be the anterothomoidal artery.
Yes.
So don't get terrified. Number one. Now I can enlarge this beak with a special instrument. I love this instrument. This is, this is
Satish
special-
sir.
Yes, sir.
Satish sir. So nicely you have given the point. We have been working for many years for inventing always a different instrument for frontal sinus process.
See now,
What
more frontal is coming in the way.
Yes.
I am removing this beak with this, this special instrument.
Yeah. What kind of a special instrument and what are the curvatures and what is the crossover phenomena during surgery?
This is an amazing tool from Karl Stores.
Yeah.
See this. See the frontal
Exactly.
thoroughly. This is articulated punch.
Yeah, so for residents' sake also, if you could say how suprabular recess can be differentiated from a frontal recess
Yes,
and how you
I
have
will.
to go
Yeah,
medial
yeah.
to
Yeah.
that.
Definitely, I will show you now. All these fancy cells, all these fancy named cells in the paranasal sinuses, mind it, all are ethmoidal cells. Like Dr. Kranti is saying,
Okay.
suprabular cell, infrabular, Heller
Yeah.
cell, Onodi cell, the frontal cell, this cell,
Heller
bone
cell.
cell, all these fancy named cells are ethmoidal cells invading the surrounding bones. That's how they are named.
Yeah.
So like what she's asking for the suprabular cell. Now that's a very, very important question, because if suprabular cell is there and if you are not aware, you can give complication. So to understand the suprabular cell, let me tell you where is bulla first. And where could be a suprabular cell. Can you see the bulla here?
Yes.
And how the bulla is ascending up to the level of the skull base?
Yes.
That happens majority of the time. Majority of the time, what happens? Like this. The bulla goes right up to the skull base.
Yeah.
The bulla from here goes right up to the skull base.
Yes.
And behind the bulla is the anterethmoidal artery. If I fracture this bulla like this,
Yeah.
you'll find the anterethmoidal artery protected by it. What's my point?
Yes.
Yes, sir.
And that's a very good protection for the anterethmoidal artery. Let me show you. Now, what Dr. Kranti is asking about the suprabullar cell. When this bulla is not ascending to the skull base, that area is occupied by a cell. Can you see the artery behind? Let me show you.
Yes, very clear. You can just
I
see the
just
leg.
fractured the bulla to show how the bulla protects the artery. See the artery there.
Yes.
Can you?
Yes. Yes.
So what I did just to show you why I approached the frontal sinus first before removal of the bulla. This is bulla.
Yeah.
I did not remove it and did the frontal sinus job first because the bulla itself protects the anterethmoidal artery from surgeon.
Yes.
Yes.
What's my point?
Yes.
So
yes.
that's an additional protection for the anterethmoidal artery. And now what Dr. Kranti is asking about the suprabullar cell means the bulla is not ascending to the skull base.
Yes.
It is not protecting the anterethmoidal artery now because the anterethmoidal artery runs along the skull base and bulla is not reaching there. And there is a cell there. So then the anterethmoidal artery remains unprotected. Got my point?
Yes.
So what is the difference? What is the difference?
Yes, sir.
Suprabullar
That is
recess and
suprabullar cell. That is suprabullar cell. You need to see on CT scan whether there is suprabullar cell. Your anterethmoidal artery
Assalamualaikum.
may be more exposed
Sir,
to be injured.
So, yeah, any difference between suprabullar cell and suprabullar recess?
Suprabullar cell and recess are same things. No difference into it. See now, recess, why do people call it recess? Let me tell you. Now, I fractured the bulla to show you anterethmoidal artery. I'll come to your point, sir, again.
Yeah.
See this. I fractured this bulla to show that anterethmoidal artery is behind. Can you see that?
Yes.
Let me clear that
Yes.
region to show you first. And what is the difference in case you don't protect the bulla? Suction and a very small marrow cell. See this. I will show you something. God has given a lot of protection to prevent complications. Still, surgeons are difficult. See, I'm decongesting to show you the artery better
Yeah.
and the recess. This patient has a suprabullar recess, I tell you. There are many names to that. Now see the artery better or not?
Yes.
This is the artery. See there?
Yes. Yes.
Running
Yes,
obliquely. This is the artery. Okay?
Yes.
And what is this small recess above?
This is the suprabullar problem.
Suprabullar.
Yes. See this. This bulla, which was coming over here, it was going on the skull base where this was the attachment of the bulla.
Yes.
See this?
Okay.
Septa which I have broken. This
Yes.
was the attachment of the bulla and the artery was behind that, protected. Okay? And this small recess is suprabullar recess. This is, what you see above is the roof. Can you see that? See, I'm using the reverse blade here, the so-called adenoid blade, to remove this tip of the bulla, anterior part of the bulla, to show you something more. And see why this has other names also. See the suprabullar recess?
Yeah.
Can you see very clear? This is also known as fovea. Fovea is a
Yeah.
literal meaning means impression. This is
Impression.
ethmoidal cell, and this roof where I am touching, this cell's roof is formed by the frontal bone. So it creates an impression on the frontal bone above. That's why it is known as fovea ethmoidalis as well.
Sir,
Fovea means impression.
yes, sir. What about hiatus seminaris superioris? Could you put in a word about that?
Hiatus semilunaris superioris.
Yes, sir.
Yeah. Let me show you. I showed you between the bulla and the uncinate process, that was hiatus semilunaris inferioris. Okay.
Yes, sir.
And the other fissure is between, look. Other fissure is between this bulla and the middle turbinate. See this space. Bulla
Yes,
and the middle turbinate. Can you see this space?
Yes, sir.
This is hiatus semilunaris superioris, and this leads to retrobullar recess. See this. This is hiatus semilunaris superioris, and this leads to retrobullar recess. And I can go behind and fracture the bulla completely anteriorly now.
Yes.
Is it required to open this space, Dr. Satish?
This bulla is completely fractured out now. Yes, sir?
Yes. If
Is it
yes.
important to remove this space? The bulla removal, is it important? If the
Yeah,
disease is only to the maxillary sinus?
No, in the isolated maxillary situation, you don't need to do that.
Yeah, that is what.
This is required in the eosinophilic and massive disease requiring a complete surgery. Not in every case. See now. What we have done, we have removed the bulla.
Yes.
And now what we have achieved, we have exposed the anterethmoidal artery running along the skull base. See that?
Yes.
Now, in the situation what Dr. Kranti was mentioning is suprabullar recess. This bulla would not have been going to the skull base. And in that situation, you would find the anterethmoidal artery like this, exposed. So if you work along this region, you are more likely to damage the artery, not aware of the fact.
Yes.
Be careful. This is the simplest way of carrying out
That means what I perceived, Satish, that the fovea, the retrobullar recess, and the suprabullar recess are the representing the same anatomical part posterior to the bulla from above downwards.
All the way.
Yes.
Now see, this is a complete anterethmoidectomy done.
Yes.
This is complete anterethmoidectomy done with preserved mucosa everywhere. Sinus surgery means functional endoscopic sinus surgery, and that function is served by the mucosa, FESS. If you remove the mucosa, it is not FESS, that is mess.
Yes.
Always preserve the mucosa, otherwise you don't preserve the function.
What about anterior ethmoid artery, which we have seen? Can it be left as such, or it should be coagulated from the center?
Anterethmoidal artery?
No.
Which we have exposed or shown just now, it is to be coagulated?
No, nothing is to be done.
No.
Nothing is to be done. You can leave it as such.
See now, that is my maxillary sinus work done.
Yes.
Frontal sinus work done. See the frontal opening.
Yeah.
And then my anterethmoidal roof work done.
Yes.
Okay?
Yeah.
Now I will change back to 0 degree.
0
Yeah.
degree. Yes.
I told you one thing during CT scan, if you remember, this anterethmoidal artery runs in the posterior most part of the roof of the ethmoid.
Yes.
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 In the roof of the anterethmoid.
Yeah.
Means behind that, the roof of the posterior ethmoid should
Posterior
start.
ethmoid. Yes.
Yes.
Now see what is there. A few millimeter behind.
Yeah.
Just a minute. Clean up. That's a very important point I'm going to mention now for orientation. Now, we have removed the bulla.
Yes.
What is this structure now? This one? After the bulla, give me the... This is ground lamella. That is ground lamella.
Yeah.
Yes.
What is ground lamella?
Ground layer.
See this turbinate. This is the middle turbinate. It has 3 parts.
Yes.
The first one lying in the sagittal plane like this.
Yes.
Then it turns laterally. This is turbinate.
Yes.
Yes.
Turns laterally to insert on the lamina.
Lamina.
So after the removal of the bulla, what you see in front of is What?
Ground lamella.
Ground lamella. Basal lamella, which is a part of the middle turbinate lying in the coronal plane. See that?
Yes.
And it goes up to insert on the skull base.
Yes.
Yes.
It goes up to insert on the skull base. And it's an important landmark because all cells anterior to it, what we have done is anterior ethmoidectomy.
Yes.
Yes.
They drain anterior to what we have done. They
Yes.
drain anterior to bulla, this ground lamella.
Yeah.
Now, all the behind are portioethmoids and sphenoid. They drain behind it. So it's an anatomical as well as physiological, importance to this ground lamella. Can you see ground lamella completely?
Yes.
How to know
Yes,
whether
yes.
there is any retrobular recess present or not?
It was retrobular recess where I fractured the bulla from behind. Just before I told you, when somebody asked about the hiatus seminaris superioris, I went into that. Behind that was retrobular recess and fractured from behind anteriorly to get the bulla out. And after the bulla, now this is ground lamella. See now the ground lamella completely.
Yes.
See how the
Yes.
turbinate is containing it. And we all know this is an important landmark because to enter the portioethmoid, we need to go behind it.
Yes.
Yes.
Fine?
Yes. Yes.
Now, before going to the portioethmoid, I will do certain things and show some important landmarks there. Now, the first of the question is, I mentioned the anterior ethmoidal artery and relationship, how it courses through the posterior-most part of the anterior ethmoidal roof. Behind that, the posterior-ethmoid starts. The posterior-ethmoid will start after the ground lamella.
Yes.
That's my point.
Yes.
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 This ground lamella superior attachment to the skull base is few millimeters behind the anterior ethmoidal artery.
Yes.
What's my point?
Yes.
Now see, this is ground lamella. See its superior attachment to the skull base.
Yeah.
See this. This is ground lamella. And
Yes.
see its superior attachment to the skull base here. This is ethmoidal skull base anterior to the anterior ethmoidal artery. This is ethmoidal skull base behind the artery.
Yes.
And this is the area where this ground lamella is inserted on the skull base. Can you see here?
Yes.
Yeah.
This is here. And see roughly 1 or 2 millimeter behind the anterior ethmoidal artery is the ground lamella insertion. And behind that, the posterior ethmoidal starts.
Yes.
That is the importance of anterior ethmoidal artery. A few millimeter behind is the upper attachment of the ground lamella.
Yes.
See, this is the upper attachment, this one, attached to the skull base, and behind that is the posterior ethmoidal roof.
Yes.
This is important because now we have to enter into the posterior ethmoid. Now, what landmark can I take to the posterior ethmoid? What are the concerns? I can open anywhere the ground lamella and go in the posterior ethmoid. What is the concern? Concern is I should not damage the skull base.
Yes.
Now, I have already shown you the upper attachment to the skull base. So, we would not like to go
Beyond that. Yes.
to make an entry there. What we will do? I will make an entry below. So
Yes.
what should be the level of entry? That is a very important landmark. I call it as a maxillary line. As a life-saving landmark for me. See this roof of maxilla?
Yes.
Draw a line parallel to it. This is maxillary line. Close to the transition between the first part of the turbinate and the second part. And here I will open into the ground lamella
Okay.
Yes.
to enter the posterior ethmoid. That is the site, safest region.
Yes.
Let me widen it big. The region is, if I go a little bit high up, see here, what is their skull base?
Yeah.
I can easily go and hit the skull base there. See that? See the skull base behind?
Yes.
Let me remove this just to show you something. That is the upper attachment of the ground lamella to the skull base. See there?
Skull base.
Up.
Yeah.
That is the posterior ethmoidal artery, most likely. See that?
Yes.
So, see the fine bone which I left in between. This is
Yeah.
upper attachment of the ground lamella to the skull base, which is just behind the
देखो जी माली होगा.
anterethmoidal artery. Got my point?
Yeah, yeah.
So the first thing is use the maxillary line and enter into the posthethmoid. Number one. Number two, I don't want to complete the posthethmoidectomy here because I don't know posteriorly comes where I accidentally enter into the sphenoid and damage the important structures there. So I have to be extra careful.
Yes.
So I will not do posthethmoidectomy here first. I will search some landmark for the posterior limit of posthethmoidectomy so that I don't enter into the sphenoid. So I will go here medially at the same point. See this? Medially and find
Superior
something.
turbinate.
Can you see?
Yes, yes.
Superior turbinate. See the superior turbinate? And if I remove the lower 1/3 of the superior turbinate, we know where the sphenoid ostium is.
Yes, it is
Yes.
there.
Medial to that.
Medial to
Medial
that.
to the superior turbinate.
Yeah.
See that? This is nasal
Yes.
septum. This is nasal
Yes.
septum. This is superior turbinate. Now, where to look for the sphenoid ostium? Now, again, I told you this is my life-saving landmark. Maxillary
Maxillary
line.
line.
If I don't take into consideration here, and suppose I look for the sphenoid ostium here, what can happen? The sphenoid
That is the-
ostium is not at the level of the floor of the sphenoid, not at the level of the floor, high up, close to the roof.
Yes.
If I don't take this line and go above that and open here, I will be right in the skull base.
Sphenoid.
Skull base.
Disaster. So
Yes.
always take this line into consideration. See this line? Line here. Stay close to the septum, not close to the turbinate.
Okay.
Close to the septum, and this is your
Sphenoid opening.
Yes.
mind it. Mind it. What I'm saying, close to the turbinate, close to the septum, not
Septum.
close to the septum, not close
Yes.
to the turbinate.
Yeah.
Step flush to the septum. See this?
Yeah.
Yes.
Flush to the septum at the level of what? Maxillary line. Can you see?
Maxillary line. Yeah.
Can you
Is
see?
Yes, yes.
Is there,
2
is
to
this
3
a case
millimeter
of the
away from
onodi
septum.
condition?
Suppose
Satish?
now I have widened it. Suppose that is the roof of the sphenoid there.
Sphenoid, yes.
If I don't take into consideration this, and if I go there to open, would be a disaster.
Yes.
Would get a CSF leak.
Yeah.
That's why this maxillary line is so important. Now, why I saw this sphenoid first before the posthethmoidectomy? Because now I know my posterior limit of posthethmoidectomy.
Yes.
My all carotid, optic, whatever are going to be behind the level of the ostium. So I will accomplish my posthethmoidectomy quick now,
Yeah.
taking this sphenoid ostium as a posterior limit. Until the sphenoid ostium, I can carry out anything.
Okay.
I can guarantee that nothing will be injured till then.
What about onodi cells here?
Whatever
Okay.
onodi cell is there or not, if during this step I don't cross the sphenoid ostium,
Yeah.
I will not damage anything. Simple.
Okay. True. So
See this
simplified,
now?
huh?
Everything I am removing.
Yeah.
Simple. See this?
Yeah.
See, this is like a box. Again, your lateral limit is lamina. See this?
Yes.
Medial limit is your turbinate. And I have an insurance here that I will never damage the optic or carotid as long as I keep my sphenoid ostium as my posterior limit of posterior
Posterior
model.
limit. Yes.
Now let me remove this lower 1/3 of the superior turbinate.
Yes.
See, somebody asked about the superior turbinate. It doesn't obstruct any other sinus but the sphenoid sinus.
Yes.
Is this the onodi cell,
Yes,
the upper one?
yes.
Okay.
See this. Now I have removed the lower 1/3. Now, if there is onodi cell or not, I told you don't cross this limit of sphenoid ostium.
Yes.
See this? See this?
Yeah.
Yes.
Now, I am at the level of the sphenoid ostium. Wait. See this?
Yes.
Suppose I don't take into consideration this landmark and keep on going behind and doing a post-ethmoidectomy. See this? I can easily damage the optic now.
Yes. Very
Can
close
be a
to.
disaster. Can be a
Yeah.
disaster. So
Yeah.
now, having seen this sphenoid ostium now, our sphenoid is behind. See that?
Yeah.
I can remove this septation and widen the sphenoid and complete my surgery on this side. As simple as that. See
Sir,
this?
in case of thick bony anterior wall of a sphenoid,
Pardon?
and in case of thick anterior wall of the sphenoid and very
Yeah.
thin,
See what
very
I'm doing?
narrow
I'm
opening.
using a Carrison punch.
Yeah.
Yeah.
I can use a sphenoid punch, Stemberger punch. I can use a drill,
Okay.
but
that-
never pull it. Use a sharp instrument to punch through. See that?
Okay.
Widen the sphenoid thoroughly. Now see the sphenoid.
Yes.
Yeah. Yeah.
I am not removing the entire superior turbinate, which is not bothering, and this upper part of the superior turbinate is important because on the other side is the olfactory mucosa.
Yeah.
See this? Everything. This is not a great sphenoid, not very pneumatized. But still, I can show you the landmark, what I see here. I can see the carotid prominence. Show you. See that? This is my carotid prominence. Can you see this?
Yes. Yes.
Yes. Yes.
See this bluish? And this
This
is
is the
going to be the optic
optic.
nerve prominence.
Yes.
Here.
Yes.
From
Yeah.
here to here, this is carotid. The optico-carotid recess is not pneumatized. I can see the size of the sphenoid is not great, so not very pneumatized. So you see this in one view, what we have achieved is the full house FESS.
What about the
Told you,
ethmoid arteries
our
here?
goal of surgery is two-pronged, to do a complete walk, addressing all sinuses. That's why we call it full house safe FESS. At the same time preventing complication, and so many landmarks we take into consideration to prevent complication right from the beginning. Every step you need a good landmark. See now with your 0 degree in your outpatient department with your 0 degree you can see everything.
Is the posterior ethmoid visible?
Osteoethmoid
think-
artery is here.
This here. Yes. Yes.
Yes, it's 4 to 5 millimeter, 5 to 6 millimeter anterior to the optic nerve. Optic nerve is here.
Yeah.
This, so this should be post-ethmoid.
And anterior?
Anterior I have shown.
Still more
Yeah.
anterior.
Still more anterior,
There.
but
That is. So see the wide opening of the sphenoid,
yeah.
maxillary, entire ethmoidal roof, frontal sinus anteriorly, both ethmoidal arteries. This is orbit. This
Satish,
is medial wall of the orbit.
there was the retroorbital cell in the frontal. So that was not visible in
Yeah,
this.
on other side, on other side.
On the
deep-
other side. Okay.
Yes.
Okay. This is on the
Here
right.
it is very, very shallow. I can tell you the location. That is supraorbital cell. And this is the middle turbinate. See how nicely it is lying close to the septum. The best treatment of the middle turbinate is not to disturb it. And if you happen to damage it, you may have to do a partial resection or something like that, bulgarization, anything.
Sir, could you tell conditions in which you at times would like to cut the partial part of middle turbinate?
Yeah, many a time.
Huge AFRS.
Massive mucosal disease, we do it intentionally.
Okay, yeah, for better delivery of steroid.
Yes. No question of blocking it further. Now see this recess.
Yeah.
This recess, it was shallow on this side, posterior to the frontal sinus, that is supraorbital, and that is quite shallow on this side. It is more deeper. See this. This is the frontal sinus, and behind this recess going up above the orbit. This is very shallow. This is supraorbital.
Yes.
Not very important on this side. So this is about the full house FESS on this side. Any
Excellent.
questions?
Sir,
Excellent.
one thing more. Sir, in the post-operative period, could you put in a word or comment upon the way of douching?
Okay,
So,
I
for
will
more
show you.
effective steroid
I will show you through
delivery.
one of the pictures.
Yes, sir. because that is a very
This is
important
the
thing.
final picture.
Yeah.
Just 5 minutes, we will irrigate with the saline. Then we'll irrigate with the Dexona. And we will leave Dexona soaked same marrow cell pieces into the ethmoidal cavity. See, the goal of this surgery now, this patient who would take the oral steroids again and again to control his symptoms. Now, we have removed the disease load. We have
Yes.
improved the access to the topical reaching everywhere in the sinus. Now, no need of oral steroids. We'll train him for douching to ensure your
प्रदीप
topical
थोड़ा देर
steroid
में हम
reaching
कॉल करते
everywhere.
हैं, है ना?
To ensure that your topical steroid
हाँ,
reaching
थोड़ी
everywhere.
देर में कॉल करते हैं, जरा एक वर्कशॉप में है. हाँ, ओके.
Any comment regarding intranasal corticosteroids drop and spray?
No, no drops, no spray. It is douching.
Douching.
Douching means you have to irrigate the way it should reach to the depth of all sinuses. my point?
Satish, there is a question. Satish, there is a question.
Yes, sir, please.
In the full house phase, if disease is to one side, should you do it bilaterally or that side only?
No, no, on the side of the disease. Why to go bilaterally once there
Right.
is no disease at all?
And then there are some comments from Ahila Swami, DK Singh, and Nasir that excellent dissection. I mean, excellent work, Satish. These are the comments. Yeah.
Achha, now-
Go ahead.
What is the douching material, Satish?
Huh?
Douching
What is
material.
the-
Douching material.
Yeah, the douching material we use is basically the budenoside solution.
Yes.
And budenoside is the one we mix in saline and do a high volume irrigation reaching paranasal sinuses.
Yes.
So,
In
let me
Namaz
show you.
position or like that.
Yes, Namaz position.
Satish,
Yes, sir.
and I want to make one comment which I heard from our one of the ENT colleague from Pakistan,
Sir.
that he heard of Taj Mahal in India, he heard of Lata Mangeshkar, but he was able to heard about Satish
Oh, come on.
in the webinars.
It's too much, sir. Thank you. Sir, can you see this picture?
Yes.
Yes,
This
this
is
is
our
the one.
preferred position we advocate our patient. And young patient can do it easily.
Yes, sir.
You know, head down
It
forward, 40 to 60 degree, and whatever you introduce, it reaches the olfactory cleft and the frontal sinus well.
Yeah.
Yes.
And this is easy. It's a prayer position. You bend down on your knees with the head forward, resting on the floor.
Yeah.
This prayer position, and you can then douche. It will reach everywhere. Our goal is to make the steroid solution reaching everywhere,
Yes,
so
sir.
that these patients can be switched from the oral steroids to topical steroid.
Yeah.
Without this sinus surgery, the steroid was not possible to reach to the depth of the sinuses. Now the surgery has made this solution reaching everywhere in the sinus. That is the role of surgery. That's why we have to counsel our patient properly. I never tell my patient that surgery is going to cure you, but the surgery is the way to cure you.
How long you are going to give the
Depending upon
douching?
yes, I
How
will
long?
do it, sir. That's a very
Symptoms.
important question.
Yeah.
So, and another position, and some people can't do the head down position. Then this
Yeah.
lying head back position. It will again allow the solution to reach to the frontal sinus and olfactory area in the equally, efficient way. So this is regarding the position.
Yes.
And we need to counsel a bit. Don't tell your patient that you will do sinus surgery and the patient will be cured. It's a joke.
Yes.
It's a joke. He cannot be cured. It is a way to the cure in the sense that we need to counsel patient. Without surgery, we can't give topical. And without surgery, you need to take oral steroids again and again, which have their own adverse effects.
Yes.
To avoid using oral steroids, to make the topical steroid using topical steroids effective, you need a sinus surgery. But you need this douching for long. And now this is to answer how long what Prakash Mukhar has asked. So tell your patient, like cardiologists tell, after an angioplasty, you have to keep the stent patent by taking anticoagulants. And the patient will definitely take, he will never afford to get the stent blocked.
Yes.
Similarly, you have to tell that if you don't douche post-operatively, you don't deliver steroid, either you'll have to take oral steroid or you have to get again and again operated. He will never miss it.
Yes.
He will again use it. So it is a matter of counseling, how you counsel your patient. Don't give them a hope that to lure a patient that we will cure you. You need surgery, you will be all right. It can't happen.
But Dr. Satish, more practical is when they are get rid of symptoms, they stop taking the douching, and then again they have the symptom.
Yes.
So will you
what you can do, these patients requires a regular periodical
cleaning up and follow up.
endoscopic monitoring.
Yes, that is there. Another question, after the polyp surgery, steroid sprays are given, the rationale and how long it should be given?
Zero roll. Now you have opened the sinuses. You have opened the access to the solution to reach everywhere. What do sprays do?
Yes.
Spray cannot cross more than anterior 1/3 of the nasal cavity.
Yeah.
They were used in the medical treatment pre-operatively because the sinuses were blocked.
Yes.
Now, once you open the sinuses, no role of sprays, no role of drops.
I think this is a clear message. This is a clear message to all, because many still prescribe post-op, say some steroid spray for 3 months, 6 months.
No way.
Yeah, please go ahead.
You need to deliver steroid. Now you open access the steroid to reach all sinuses.
Right.
That is the goal of surgery. The goal of surgery is changed now. The goal of surgery is to make topical steroid effective. You can use topical steroids long lifetime without or hardly any adverse effects as compared to the oral steroid. That is the goal.
Yes.
Sir, how do you tell the patient? Do you get a preformed budesonide for these patients, or do you tell them to make it?
No, we tell them to make in a range of a solution 250 microgram per 250 ml to be delivered every time. In the sense, what we tell them to mix 1 ml of budesonide in 1 liter of saline.
Saline, okay.
Yes.
And that they can.
Milligram. Now see, 1 milligram only. Out of that, 250 milligram is being delivered every time.
Okay.
There is hardly any steroid, and that too only topical. You rinse and it comes out immediately.
And how much?
Hardly any systemic side effects. We have seen our patient using for years together without any side effects. So many studies done with no effect on the HP axis.
HP axis. And sir, how many, like, would you say do it
once daily, once daily, twice daily?
Yeah, initially to begin with, 3 months is twice daily, without until it heals completely. That's what I was coming to. Then on a regular periodical follow-up, you can see when everything heals up and patient's profile is not very eosinophilic. That is why I put up this slide. You can start reducing the concentration and the frequency. You can reduce the concentration to 0.5 milligram and once a day. The still patient maintains the mucosa well. You can call after a month or two. If it is maintained well, you can still reduce. And if they start developing edema or polypoidal mucosa, you can again increase the strength. So depending upon the symptoms, depending upon the endoscopic finding, you have to keep playing with the dose and frequency, you know. And how do you ascertain is this slide, that how eosinophilic the patient is. You need to have a good information of the mucosal eosinophilia. That's why we take at least one sample of the mucosa, what we remove for the histopathology to see the mucosal eosinophilia. If that is more than 10 eosinophils per high power field, is a straightforward, you can tell your patient, boss, you may require this solution for lifetime because you have too significant eosinophilia.
Yes.
Don't think of stopping this on your own, otherwise you may have to come back for the surgery. So there are so many things. This is our investigation panel for every patient of particularly polyposis, to rule out any adjuvant pathology, adjuvant comorbidity. This is not a simple sinus disease. Many a times it's like a syndrome. You need to rule out, antibiotics particularly hardly ever needed because this is a eosinophilic disease, and still the need of antibiotic can be ascertained by getting the CRP procalcitonin done. If it is high, then only the need of antibiotic, otherwise no need. You have to get a eosinophil count, IgE, immunoglobulin deficiency is not uncommon. In up to our 10% of our patient, we find some sort of immunodeficiency, particularly who come for, revision surgeries, massive disease. There are so many immune conditions affecting the this disease as well. So if immunity is low, whatever you operate is never going to work. You have to improve the underlying immune condition. Aspirin sensitivity, if it is there, particularly in polyp patients having asthma, we must get done the aspirin sensitivity. Now we have over 350 patients who are undergoing aspirin desensitization because their basic pathway is different. Disease pathway is different. Basic underlying pathophysiology is different. The underlying pathophysiology is the arachnoid acid dysmetabolism, wherein they're sensitive to aspirin, so you have to desensitize them. Otherwise, more and more leukotrienes will form, more and more polyps will form. 100 times you operate, he is going to come back again. So all patients with polyps and asthma must be assessed for aspirin sensitivity. Vitamin D again must assess and improve the immunity by supplementing if it is extremely low in mucosal stuff. So these are the investigation you need in almost every patient to prognosticate them. Every patient is the first question, Doctor, will I need to come back for surgery again? I have Googled this surgery is notorious, this disease is notorious, and patient have to repeatedly get operated. And you need all this information to get the patient's profile, disease profile, ongoing disease profile, to answer him that how severe your disease is. You can't treat every patient on the same line. Chronic sinusitis has several endotypes. Every endotype has a different pathophysiology, and you have to treat separately on that line. Like allergic fungal sinusitis is a different pathophysiology. This allergic respiratory, AERD, aspirin exaggerated disease, is a different pathology. Cystic fibrosis has a different underlying pathology. You don't have to treat every patient on the same line, rather going into the pathophysiology of the disease and then operate or take a call for management.